Thank you very much, Jens. It's truly a pleasure to be back here. I think I actually maybe even gave lectures at the very first SSF spine program. Um, Jens and Rod are just incredible guys and have built such an incredible program here. The lab is the best program probably in the world. This program, as you've seen some of the metrics, 18 million people, interfaces in various different ways. Incredible program, but it's Rod's vision. It really is. It's Rod's vision, which when he was a medical student at UCLA and I was on the faculty, Rod and I think some of these things were born back then, but they were in his mind, not mine. So he's included me as part of it. So I always take a little straw poll. How many people here are residents? Oh, lots of residents. Okay, yes. Okay, Kojo, you get out of here. How many fellows? A bunch of fellows. So, okay. All right. How many from orthopedics? A bunch. Okay. How many from neurosurgery? A little more from neurosurgery. Otherwise, it's pretty balanced. That's great. That's great. This is truly a great program. It really is. And enjoy the lab. Enjoy everything. Enjoy your training. You heard a little bit of that yesterday, but I will tell you. Being a chief resident, at places like where you all train, it will be the best year of your life in a lot of ways. And probably the Kojo is nodding his head, yes. Your chief resident year in your training and your fellowship year, hopefully, they're the best years of your life. It doesn't go downhill from there, but let's just say the challenges are more later as life goes on professionally, which is good. And I'm going to talk a little bit. Let me just make sure I got the slides going, right? Okay. Well, these are about my origins, where I come from. Top middle picture, that's my dad. My dad was the first neurosurgeon in not just Montana, but 5-state area back in the 40s. And that's quite a set of boots to try and fill. And anyway, he told me, he said that all these things you've heard a lot, exceeding the master and things like that. And it's like I try and teach all of my trainees, residents, fellows, and actually I was operating the other night with Terry Kim. He was doing a far lateral disc, and I just say, you know what, you're better at this. I'll help you. And so he's exceeded the master in a lot of ways. But anyway, enjoy your life as well along the way. And with this generation, I think you probably do anyway. Your generation is a little bit different, which is in a good way. That's a great thing. I have a lot of disclosures, a couple at the bottom, where I'm a consultant for the PRCA, Pro Rodeo Cowboys Association, Professional Bull Riders, and the NFL. Those are kind of fun ones along the way, but it's what I do. It's what I do the least, but I probably enjoy the most. So I did a little bit of a poll. Who's used spine navigation? Oh, a boatload. Okay, that's good to know. That has changed immensely. I've given this same lecture, not the same one, but updated hopefully along the way. And it used to be a real minority. Okay, so I'm glad, because this is something, and I'll go through a little bit of the background. If you haven't, I guess I shouldn't even ask who wants to use it, because it looks like almost everybody has. What should spine navigation do for you? And that's what I'm going to talk about today. And actually, toward the end of the talk, I'm going to just show a bunch of little things, which they were great little cases along the way that I think are really illustrative of where navigation needs to be, not just where it came from and what we're doing currently. Accuracy, we know all about that stuff. In fact, I'm going to fly through a whole bunch of slides like that just kind of give you an overview. Yeah, and who thinks spine navigation needs bugs worked out? Of course, everybody does. Who uses their phone for GPS? I'm not going to ask you to raise your hands, because everybody does, right? Is there anybody who doesn't? That's probably a better question, right? I mean, we use it just to find your way around traffic. Yeah, truly you do. Okay, here's a few little jokes along the way. They outlaw cell phones. How am I going to get anywhere, right? And then the pilot sitting in the back says, I'm flying this sucker on my iPad. Okay, what are the origins? What are the origins? Okay. William Röntgen, a century ago, okay? Those aren't Google glasses either. That's not some virtual reality thing either. This guy was And here's a cool slide, okay? World War One. Um, French surgeon Huget. I don't know that much about this. One of my fellows actually came up with this slide a couple of years ago, and I love it. But they were taking bullets out of people with this fluoroscopy thing that they put on their head. And those aren't, virtual reality glasses either back in 100 years ago. But imagine the radiation that came through the bottom of the patient and exposed the surgeon to, not just the patient. But and here's, a real incredible innovator in the world, received a Nobel Prize appropriately. Uh, Jeffrey Hounsfield in London, and invented the CT scanner. Incredible stuff. The CT scan, I remember going and seeing the first CT scan with my dad in the 70s. And he took me in because I remember they used to do angiograms in patients that they would do a carotid stick, and I watched him do that when I was a youngster. And then he said, "You got to go see this new machine. It's a CT scanner." Yeah, well, it changed things. It certainly does. Well, what about navigation? Okay. It basically is like celestial navigation. Ian Kalfas actually wrote a paper back in 1995 about it, frameless stereotaxy. And that's what a lot of this has evolved into, but it's come a long, long way. And it has its roots in celestial navigation. It really does. A mariner's sextant, it basically is utilizing points in space, literally, and also in the room when you're operating. Okay, and I'm not going to go through all these things. The frames, the computers, but this is back in '97 when I started using this stuff. And here's how it just happenstance is that somebody, when I was at UCLA on the faculty, which I did my residence there and then stayed on the faculty 10 years, is that we had this computer system that was given to the brain surgery guys, and they kind of just shoved it to the side because they had frames on that they screwed into the patient's head, and they had this frameless stuff. And I said, let me take it to my lab. And so we started doing navigation in the lab. In fact, some of the first papers that we did in the 90s were putting thoracic pedicle screws in cadavers and showing a learning curve. But this stuff is that you had to get a CT scan, you put it on a little drive or a tape. It was actually a tape, a little cassette tape, and you put it into this computer system that had a camera. And, it looks kind of like what we use today, except it's a pretty basic version. And then we had this reference frame. And we started using this thing, okay? We started using it in C1 and C2 because the Moggerel screws, which were really innovative at C1 and C2, had a 4% injury of vertebral artery injury, and there were deaths. There were mortalities and fatalities. It was a serious problem. 4% is a pretty darn big problem. Anyway, we looked at that and said, what can we do with this? And actually, Orrin Block was a medical student. Langston Holly was our resident, and John Parks at Stanford, Obasi's in Kansas, Keith Kim's at UC Davis. It's a great bunch of people that we put together. In fact, we had a little competition with Barrow, is at the good friends over there, and they were saying, well, certain people you can't operate it on. And they said, you can operate on all of them if you use computer guidance system. And this paper is what showed it, and that was back in '01. So anyway, I got to get through the history here. We did stuff like navigated off the front of the spine, frameless stereotaxy, and we used this in different places. We used it in thoracic surgery, inside of the chest to take out big thoracic discs. We use it with the endoscope. You've all seen this video. The CT scan is what really changed things in 2006, is that we had to use this, uncoordinated system of CT scans before, and tapes and stuff like that, and CDs. But the CT scanner intraoperatively changed the whole thing, where instantaneously we had registration, and then you could point and shoot, and it was like a video game. Well, it was from the beginning, but this is what really, really changed it. We navigate everything. You can navigate everything. Any part of the human body, okay? What it pertains for us is for the brain and the spine. And so, but you can get to any place and you can navigate any place as long as you can affix some reference frame to the patient. And this is why this talk, I thought is really good for residents and fellows. It's where it came from. I mean, putting pedicle screws and navigation, it used to have errors in the 10% range. And then it was fluoroscopy, got us better in the 8% range. And navigation, I think that it's way less than 4%. This is an old paper circa 2010. And these are just some of the small corridors that we work. We saw Dave Skaggs give his lecture yesterday about the robot and putting the screws across the pars. I mean, that's a tiny space, incredibly tiny space, and the precision of that is incredible. But, we use this in the cervical spine, thoracic, lumbar spine. I mean, these are just some of the many places. In fact, we use it to put bone grafts in C1 and C2, and here's the facet joint, and here's where we put it in. And so it's navigate everything. In fact, I have a bunch of talks that I've given here, and it says navigate everything. Well, it's where we're going. So here's some patient with a congenital deformity and a 3mm spinal canal. She was a nurse at a training institution in the LA basin and came to me. She also had a big brain tumor, but that was asymptomatic. But anyway, we did the decompression. We put screws in. That's probably the longest screw I've ever put in cervical spine in a human. But she had a clipple file problem, and we just didn't have many points of fixation, so you had to maximize every single one that we did. Anterior procedures of the cervical spine, we just mount a reference frame to a Mayfield, and I don't always attach the Mayfield to the bed or the frame, is that if it's something I'm doing at the craniocervical junction that I'll show you, and here's a case. In fact, here's a Boeing engineer came to see me because he had a deformed odontoid that was a cranial settling problem, and basically this big bulbous odontoid was squashing his brainstem, and he needed, that's not going to get better if you decompress him from the back. So we did a transoral on him, and here are the pictures. Navigate the transoral. The decompression is the most important part of that operation, okay? And then we turn him over from the back to do the fusion. I mean, that's the easy part, okay? It's become where in my shop, putting the screws in any part of the body, that's the easy part. In fact, I almost don't do them anymore. I don't do them. I let the residents and the fellows and the young attendings do them all. Is that, okay, you guys are good at this. We've learned how to do it. So here's just a whole bunch of cases. Here's different places. Here's a guy had a couple of different malignancies in his life. He's in his 70s, had a weak arm, had a biopsy. This is a schwannoma. That's not a very favorable place to get to, right? Here's a vertebral artery. Here's a vertebral artery. The vertebral artery is open. It's wrapping around all the nerves. It's not pushing on the spinal cord. I don't know. Jens, how do you get there? Front, back, sideways, upside down, whatever. Okay. So it allows some creativity. Okay. Of course, we did the angiographic studies on him. Here's what it looks like on a CT scan. It's a benign tumor. Okay. So we do it from the front side. Here's what the reference frame is. There's some things need to change here. The distance of this reference frame to where we're operating on, it needs to be better than this, but this is just some of my goals that I'm working on how to do these things. But it works, okay? It's not down to 1 or 2 millimeters accuracy. And don't let anybody tell you that there's such thing as submillimetric accuracy, okay? The CT scan is limited by the thickness of the cut. You have a 1 millimeter cut, you have 1 millimeter accuracy. That's something you just have to keep in mind. But
did we lose the transmission?
Oh, what's happening?
Yeah.
Well, they say, some people present slides, other people present ideas.
How much longer do you How much longer?
So anyway, we went through the front of this guy's neck, and we took the tumor out from the front. And it's a debulking of a tumor.
There we go.
There we go.
Wow, good job, Ben.
Okay.
Wow.
So anyway, CT scan. Here's the intraop navigation. We could see his vertebral artery. We worked around it. It's somewhere right in this neighborhood because the opposite one's there. We didn't have intraoperative angiogram, but we certainly knew where things were. And this is debulking of a benign tumor. And you can take it out. And I've done a bunch of these. I have a series of them going. There are some interesting deformity things that we work on that are craniocervical junction. This is a guy who is a well-known fashion designer that had cancer, he had radiation, he had an infection, and then his head started tilting, and he had this problem that looked like this, and did a 3D rendering. And it was a mess. So we ended up having to do a transoral operation on him to basically dismantle everything, and then turned him over and did it from the backside as well. I'm going to go through all these slides quickly. What am I supposed to be done?
Yeah, now.
10. Okay. And so anyway, here's the size of graft we put in. I'm going to skip right to the end here. Here's a craniocervical or a cervical thoracic junction. Correct those. I taught myself how to do PSOs at the cervical thoracic junction with navigation. Thoracoscopy. I'm going to go to the end and show a few cases and take about 1 minute here. Keep going. Small pedicles, tiny pedicles, navigate them. I mean, the navigation, you shoot it through the costovertebral joint. The pedicle is something that you simply pivot around if the pedicle exists. Fixation, I'm trying to skip to the end here. So here's a patient who had an epidermoid in his sacrum, and our peds guy came to me and said, it's infected, there's a CSF leak, I can't fix it. And I said, we're going to navigate it, and we're going to use CT with MRI scan. And we went in and finally cleaned it all out. We fixed the CSF leak and solved the problem. Here's a patient who had a tumor that's been multiple laminectomies to remove tumor in this poor young guy. And it's a CT MRI merge, so we could use the CT, and we could navigate because he had, on axial view, he had some big masses of tumor, so we use it for that. Here's a patient who had a coccydynia, and she had also a mass associated with it, which I'm not showing you on the MRI scan. And it's like, we need to know exactly where we are to do a coccygyectomy. It sounds like overkill, but it was actually useful in that case. Here's some everyday cases. Here's a foraminal problem. The guy's got a foot drop, and he doesn't have any pain, but he needs a decompression. Doing the decompressions like this is a we even skipped doing localizing x-rays because I put a reference frame on the patient, and we just navigate from there. Here's another guy with a leg pain problem. Okay, you can't get to some of these things unless you really know. I'm not confident about my ability to navigate there. Jens is a brilliant guy that can get himself anywhere in the spine, but I think that I like to have some kind of navigation like this. This is probably a good slide to end on. So I think we can navigate a lot of everyday cases. We eliminate some localization, but we need more simple, accurate things that can be done quickly in the operating room with better technology. So anyway, I'll end there. It's been a pleasure being here.
What a treasure trove. We need to have the J. Pat Johnson and David Skaggs see the show here for all day. Just one quick thing. So when you navigate one of those whole spines, assuming it's not fused, dysplastic all over, and you're instrumenting whatever, 12 motion segments or more, do you re-register every segment, or can you skip some levels, assuming that there's mobility between these levels to not lose accuracy?
Well, I think some of that's a mechanical question. What can you skip? But no, we instrument pretty much every level. I used to want to try.
Navigate.
Yeah, we can navigate every one of them. In fact, when somebody has a big fusion mass and there's nothing visible in there, and you're going to radiate yourself with a lot of fluoroscopy, I think we can do it with not just the radiation issue, but we can certainly fire screws down a big fusion mass through it and know exactly where we are. If we have a screw that's still in the spine from a previous surgery, put a J-frame on and do adjacent segments. But that's one of the things that needs to improve, is how big of a slab of human body can you image? I mean, it's not enough to be able to do 3 or 4 levels for me. I want to do 6 levels, but what's the range that you can do? In fact, we had some accuracy issues that we worked on, and that it's probably about 4 or 5 segments. That's why we try and put a reference frame in the middle of a big segment. Am I answering your question, Jens? I think I am.
Any other questions? Otherwise, in the interest of time, I want to move ahead. Thank you, J-Pat. Always a pleasure.